السلام عليكم جميعا. We start our session inshallah today which talk about clinical practice guidelines. سيبدو لي الحضور يمكن اللي حاضرين في القاعة بس يمكن only 11 person 11 بس. We'll start first lecture with Dr. Jassim. He will talk about clinical practice guidelines development. Dr. Jassim is consultant in neonatal ICU, fellow of Royal College of Physicians and Child Health UK, Saudi Board of Pediatrics, fellowship in perinatal and neonatal medicine, assistant professor of pediatrics, King Saud University, Riyadh, Saudi Arabia. Dr. Jassim.
Okay, Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Abdurrahman. Thank you, organizing committee, scientific committee, for inviting me today to talk about this very important topic and efforts we have done in the Saudi Neonatology Society about the clinical practice guidelines and the project to make it like national project to improve and to collaborate between health sectors and make it like national evidence-based clinical practice guidelines for neonatal healthcare in Saudi Arabia. It is a collaborative approach and guideline between health sectors in Saudi Arabia. As a clinical practice guideline, I think everyone in practice of neonatal medicine knows how important is the presence of unified clinical practice guideline. One of the important things that make best evidence-based decision and patient in time efficient manner. So if we have a guideline in each center, we have to obey and follow that guideline, which make us like we talk in same language. Not one baby will be managed in a way today, and with other physician it will be a different, or in health sector will be in a way, and another health sector managed in different way. So it will make like best evidence based on the criteria of that situation in that country. Is not like we just imported from different guidelines. Also, it help in reduction of practice discrepancy, release the tension between the healthcare cost and quality. Because if you do everything, for example, in neonatal sepsis, you can do everything for every baby. But with the evidence-based clinical practice guideline, we can use our resources with the best available evidence to save our babies. Initially, we consider in Saudi Neonatology Society a lot of objectives. We have 7 objectives since the started of the society a long time ago, and we read in between that our objective to draw out a recommendation for neonatal care at different levels. From that objective, we make a strategic plan, and we try to look into how to improve and how to do that objective on the real time and on the ground. This is at one time it was the organization chart of the society, and in the scientific committee we consider all these committees. They were belong to the scientific committee. Then we look into how to improve. We implement a lot of this is the conference, annual conference. The committee for research already talked to Dr. Sajjad yesterday. The Journal of Clinical Neonatology, father of that journal, Prof. Saidi. Then clinical practice guidelines. So we make a committee for practice guideline to improve the objective of Saudi Neonatal Society. Then we plan how to proceed with the clinical practice guideline. We have a very long preparatory phase. Initially, we selected the topics which needed mostly by the healthcare community. We don't like just to start any topic. We make a long selection between topics, what we needed in Saudi Arabia, more priority than others. Highly skilled team were involved in different CBGs. Workshop introduce team to each other and work scheme. We did maybe 3 or 4 workshops to train people on the clinical practice guidelines adoption system and how to proceed. Then we create small working groups to address different topic at different times. Then we start the journey. During the team creation and selection, we try to use multidisciplinary team. So we choose from neonatology, methodologist, Dr. Yasser, he's not with us today, but methodologists play a very major role with us to adapt and adopt our clinical practice guideline. Nursing, they were part of us. Other related specialty like in pediatric infectious disease, in sepsis, ophthalmology, in case of ROB and other specialty. Clinical pharmacists also, they were involved, and community representatives were planning to involve, but unfortunately we couldn't find a very suitable representative, but it was planned initially. Even we use from different health sectors to make easy implementation and to hear from different health sectors. So we choose from Ministry of Health team, Ministry of Education, National Guard, military, armed forces, and private sector also we choose. So it will reflect on all health sector in Saudi Arabia, and we try to modify the guideline according to different situation. Then we select 5 clinical practice guidelines. All of them reach to the stage 7, which is the approval stage, except one, enteral feeding for preterm infant, because after this details, rigorous search, we couldn't find published clinical practice guidelines, so we cannot adopt any guideline for enteral feeding of preterm infant. Although the Saudi Neonatology Society started a consistency-based clinical practice guideline. That one we will go for 2023 for de novo adaptation or de novo creation of CPG. The other 4, HIE, which is very important and very highly demanded with a lot of controversies, retinopathy, prematurity, neonatal sepsis with the help of pediatric ID, normal newborn infants, and we summarize in normal newborn infant a lot of routine care at birth, and Dr. Amal Zubani will talk after me about this clinical practice guideline. Then we registered our protocol of practice guideline in International Society, International BRUS Bureau, we call it BRUS Bureau, International Prospective Register of the Systematic Review. So it is internationally recognized even before we start, and they approve our methodology and our result. Why we choose evidence-based? Because we have 2 types of clinical practice guideline. Either we talk about evidence-based guidelines, which is very detailed discussion about the methodology, or we talk about consensus expert-based clinical practice guideline. I don't like to go into more details of methodology, but we have 4 phases. Setup phase, we will select the topic, we study the feasibility of the guideline, and team formation, adaptation, and then we have a plan. Then the adaptation will start with the health question, BIBOS, and eligibility criteria. We make a very detailed search. We use Librarian for that one, and Ms. Layal was very good help for us, but she gave us very long, a lot of citation, 22,000 and so forth. So we spent very long time to select that citation. Then we use the agree to instrument to assess the quality of that guideline, to choose which guideline is suitable more for us and with evidence base. Finalization of phase with external review, and we will go into the other 2 phases shortly. This is how it looks like Prisma chart when we make the clinical practice guideline and we criticize and we see the citation. For example, we have, this is Prisma chart for the neonatal sepsis, and we have very rigorous, we use for midline, MBase, senile, and Web of Science, a lot of even meta-analysis, and we search the index of articles. Then we end up with 6 only citation. Then after that, we review it and we make our conclusion about the clinical practice guideline. This is how we extract the data. We find this is the management of neonatal sepsis. We have 5 guidelines, or actually it is 4, but one is divided into 2 parts. But we put it into the recommendation matrix, then we compare all the recommendation together. Dr. Rana Al-Maghribi, I think she will talk about neonatal sepsis and how the guideline help us into improving the adaptation process. This is how look like the assessment tool of the HIE CBG. So we use agree to. See, we have 2, I think it's working, no. Pointer. So this is the Canadian, and this is the Queensland, and how we assess different domains. So the scope of purpose, how the clinical practice guideline assess their scope, determine the scope and the purpose, the stakeholder involvement stated or not, how rigorous for the development. See, all of the 2 international guidelines, they have a very low percentage of rigorous development. At the end, we have we use the overall assessment, which is for Canadian 63, for example, in this Canadian guideline for the HIE, 63% and 83% for Queensland. Overall assessment, we have 4 team members use, and 2 of them, for example, said yes, we can adapt it, 2 they need some modification, and 0 assess. So we have 4 different assessments at each guideline. So this is, after that, we adopt this, for example, guideline. This is for sepsis. And then how it look like, the guideline later. I will not go into details. You will see it after approval, and maybe our colleagues, they will present some of it. So it is very detailed, what we will do for timing, for example, of antibiotic, or what investigation, and so forth. How this is how it look like for final. There is some diagrams and help into that guideline. After approval, it will be very helpful, and there is a lot of summaries and algorithm with tables like this. Risk factors, indicators, we put it into very handy illustrative tables. This is algorithm, baby on antibiotic treatment for suspected infection. For example, we adopt this algorithm. Now, after we do this very long journey, it took around 7 to 8 months, we sent for very unique and international recognized reviewers. Dr. Hani Ali, chairman in the Department of Neonatology in Cleveland Clinic Children's Hospital.
1 minute.
Okay. Professor of Pediatric, and Professor Ivan, Associated Professor from Columbia and from Hamilton, Canada, McMaster. Then we translated into layperson translation, and we send final version for approval of international or national organization. So in summary, we make protocols. We register in Prospero, international organization. Rigorous search with very detailed citations, selection of citation, evaluation of citation, adapting of the clinical practice guideline. Then we send it for external reviewers, international CBG registration, and then we send for approval. This is first publication. We published the appraisal guideline of systematic review of neonatal guidelines and Fortnese in pediatrics. Those work, it will not be finished with 1 man or 2 men. We have a very long and very huge team. And I would like to thank all the team who participate with us. In HIE, we have Afnam from pharmacy, Aisha from nursing, Dr. Ayman, a neonatologist, Abdullah Al-Anizi, neonatologist, Ibrahim Al-Hifdi, our senior consultant neonatology, Yasser from obstetric, perinatology, Asma, neonatology, Ahmed Al-Ayubi, obstetric, Muhammad Abdul Mawla, neonatologist, and we have Dr. Umar, team leader, Dr. Yasser Layal, and myself. Retinopathy prematurity with Dr. Abdul Hakim Gattan, neonatologist, Imad, neonatologist, Hissa, clinical pharmacist, Latif Al-Mahmoud, neonatologist, Dr. Mansour Al-Qurashi, consultant, Syrian consultant neonatologist, Professor Ahmed from nursing, Dr. Sameh, consultant neonatologist, KFMC, Salih Al-Amro, he is ophthalmologist and he's senior ophthalmologist, Dr. Abdul Razak from Princess Noura, Yasser Layal and myself. This is constant names. Enteral feeding, this is the team, but unfortunately we couldn't finalize it because the reason I mentioned. But Dr. Fahad Al-Aql, Fahad Al-Harbi, Professor Ahmed from nursing, Abdurrahman Zahrani, Ra'fat Musalli, Yasser Layal and myself. Neonatal sepsis, Dr. Adnan Hadid from King Saud University, Amir Al-Darwish, clinical pharmacist, Badi, obstetrician, Ahmed, professor of nursing, Abdurrahman al-Nimri, our president of Saudi Neonatal Society, Dr. Rana al-Maghribi, consultant pediatric ID, Abdurrahman al-Mihiri, our senior neonatologist, Nawaf al-Dajani, team leader, and ourselves. Normal newborn, Al-Anud, clinical pharmacist, Ali Al-Mudir, senior consultant neonatologist, Aisha, nursing, Heidi, neonatologist. So if you can see, Muhammad Al-Hindi, Saad Al-Saidi, Khalid Al-Kawi, it's different specialty. Amal Zubani is the team leader and she will present the next talk. Yasser Layal and myself, you can see that they are in different specialty and they help us a lot into how we can implement and tailor the two teams. Thanks to all teams, a board of directors from SNS, Saudi Health Council, Saudi Society for Health Specialty, MOH, and our team. Thank you.
Bismillah, assalamu alaikum. Our next topic, inshallah, will be the topic of normal newborn care. Will be presented by Dr. Amal Zubani. Dr. Amal Zubani, she is a consultant neonatologist. She's head of section in King Faisal Specialist Hospital and Research Center in Jeddah. Dr. Amal, welcome, please. Thank you.
Thank you so much. Assalamu alaikum. يعطيكم العافية جميعا. First of all, I would like to thank Society for their invitations to be one of their distinguished speakers. At the same time, I would like to thank them again, including Jassim and Dr. Yasser, of course, Al-Prof Nimri, for giving me the opportunity to share one of these clinical practice guidelines. And of course, my special thanks to the team, which is I work with them, despite that our busy schedule. But Alhamdulillah Rabbil Alameen, we are able to proceed for the things, inshallah. So basically, it will be the routine care for neonate and newborn, and as you see, it's already registered SNS CBG 03-01. I don't have anything to disclose, and always this is the first picture I actually borrowed from Prof. Nimri, that every time actually we comes and we think that we're gonna teach, we're gonna give few points, we discover ourselves actually learning. And the best thing when we learn, that means we will grow 100%. So it's mirrored to each of other. So as an introductions, and I would like to say that this is actually taken from the paper Tamam itself, which is we are already, inshallah, going to publish it very soon, inshallah, that after birth, most of the full-term infants and the early-term infants require normal neonatal care to make a successful transitions to the extrauterine life. The most important things as well, that the major component of the routine care include delivery room and transitional care, including the early bonding, and newborn assessment, including a comprehensive comprehensive review of maternal history and a complete physical exams. So our recommendation went through were adapted from 5 main sources of the clinical practice guidelines. This include is NICE, which is the Neonatal Institute for Health Care Excellence, and the Royal College, which is basically both of them in UK. We have the United States Preventive Task Force, and we have the Canadian Cardiology Society and the association as well, and we have the European roundtable meetings as well, and of course using a normal methodology which is from the KSU and modified as well. So what exactly our target? Our target population is the normal newborn. The intervention and the practice consider is routine care after delivery. Of course, we have the people with the stakeholders, which is from everywhere: physician, nurses, pharmacists, laboratory, and all this. And the most important things is actually the outcome. What's the major thing we need to know about that? So infant health, which is basically include the physical examination, serious illness, bed sharing, of course, breastfeeding, because we have been talking about that in the last few days, and emotional well-being and bonding with the baby. And of course, the health setting, it's all the primary, tertiary, secondary, and tertiary care center across the country. I would like to say for the quality of evidence, because again, this is very important. We know that from institution to institution, from association to association, we know there is different definition of the evidence. Some of them use the word of must, could be, maybe. Some of them use A, B, C, D, and some of them they are using high quality, low quality, and moderate quality. For the purpose of our evidence for this clinical practice guidelines, we look into the evidence with high quality, and we define what exactly we are looking for: the high quality, the moderate quality, the low quality. In the same times, we look into the recommendations, and we defined what exactly the recommendation we look for, which is the strong and the weak. But I would like to mention is very important as well when it comes to the quality of evidence and the recommendation. It comes to the patient themselves. That means the patient has the right as well to be selected and to be one of those categories and to be involved in these clinical practice guidelines. Even the physicians, when we come to the physicians, the recommendation that the physician has to use their knowledge, their practice, and the evidence-based medicine in order to practice the right care for those normal newborn, not only to depend on his experiences and in his practice. And again, and this is the most important, and this is the message for the stakeholder, which is basically the policy makers. They need to know 100%. They have to set a policy, they have to set a guidelines, and the most important part of that, they have to do the quality improvement on it to ensure whatever they are delivering is the optimal care for those specific patients. So as a key recommendations from the paper, we came with the management of postnatal care, which is basically include the assessment and care of the babies. Simply, that means the baby is feeding, urinating, pooping, and we look into the most important one, which is, again, we didn't find a guidelines for it, but we included it, which is the hearing, the jaundice, and in the same times the metabolic screen for them. We look into the bed sharing, and we really indicated for those what the things they need. They need to be sleeping, for example, in a firm mattress rather than they will not sleep in the sofa. The family or the parent, they will not share if they are a smoker or in any medication can cause drowsiness. So this is again is very important. Promoting the emotional attachment, and when we talk about the emotional attachment, we look into the interaction between the parents and their babies, which is basically face to face, skin to skin, and all that. Symptoms and sign of illness in babies, and planning and supporting babies feeding, which is again very important. This is adapted from NICE from 2020. When it comes to the ocular prophylaxis for the gonococcal, again, the only message which is I would like to highlight it here is a mandatory and a standard of care. This is no questions, no doubt about it, and this is again from the US guidelines. The other thing which is very important, which is I will not spend time because my colleagues, mashallah, tabarakallah, Ali al-Mudir mentioned it the other day when they talked about the critical congenital heart disease, but we emphasize it in our guidelines that it has to be done between 24 up to 36 hours. It has to be in the right hand and either foot, and normal newborn, whenever you have abnormal result, you have to go to the next step, which is repeat, and then if we have an issue with the repeat, you have to go right now to echo and the cardiologist to be involved. When it comes to the umbilical cord care in the newborn infant, remember that application select antimicrobial agent to the umbilical cord does not provide a clear benefit in the hospital setting or a high resources countries. In fact, reducing the bacterial colonization may have unintended consequences for selecting more virulent bacterial infections. So just general statement, keep it dry, take care of it, make sure that you are not doing anything, don't make it wet and all that. And this is again adapted from American Academy of Pediatrics. Also in our paper, we mention more details, and my colleague Selma from nursing yesterday did an excellent workshop about it. In fact, they required, or they asked us actually to do it more frequent about skin care. We included everything when it comes to the skin care. The first cleansing, we also would discuss a routine bathing, when exactly the best time to bath those babies, what's the safety we need to take it while we are taking all of that, the liquid cleanser for bathing as well, and how you will care about the diaper rash, and the use of oils and the other things, which is very important. Very, very important when it comes to the clinical pathways, because remember guys, the aim of the pathway is actually to improve the quality of care, and in fact is reduce the variation, and this is the most important things. When we reduce the variation, that means we are going for a standard of care as well. Amal Dubani is not different than Jassim, and if that variation happen, why it's happened, why you took care, and this is the reason behind it. It comes to the most important part of the clinical pathway, which is maximize the outcome of those specific age groups. So our age group in this clinical practice guidelines is the normal newborn, and again this is adapted from NICE. When they look during the COVID era, which is basically you are taking care of the baby and in the same time you are taking care of the mother, what the things you will look into that, and in the same times planning and supporting for the feedings as well. How important after the delivery is just to give huge information to the mother, to support the mother and to support the babies as well. So basically you are taking care of the baby and the mother in the same time. And again, this is the first one, which is I mentioned it earlier, when it comes to the assessment of care, the bed sharing, the symptoms, and we link also from where we get those adaptation as well. Again, the pathway for the critical congenital heart disease is very important, and all of us, most of us knows about this one. So we put it in our clinical practice guidelines, because again, you want that peripheral hospital as well to understand what the things to worry about, what the things they look into that. And we even include for them what's the critical congenital heart disease lesions, and in the same times what is could be a heart lesion which is require an immediate interventions in order to help those physicians and those caregivers where to detect the problem. Okay, there. This is again what exactly written. So whatever you would like to have, you have to have the permission from SNS, and I'm sure they will send it to you guys. I will not mention about, because Jassim already, mashallah, tabarakallah, mentioned all our colleagues, but really I would like to thank Jassim and Dr. Yasser, because they were so patient, in fact, with us when we go through that. Already Jassim touched what's the inclusion and the exclusion criteria. This is exactly how many of the years of publications and which guidelines we went to, and that exactly what the index mentioned by Jassim as well. If you see, you will see NICE and the Royal College, in fact, touch typically what we are looking for it for normal newborn. And this is again the steps which is mentioned by Jassim as well. And as you see, alhamdulillah rabbil alameen, we did very good job on the selecting most of the things. And if we didn't selected it, we will put why we didn't select these guidelines, okay, here. So the question is right now will be, where are we right now? So the goal, the first goal actually is to publish this one in the systemic review of guidelines, because by publish this one like Al-Arubi, we don't need the permissions here. But the second goal, which is the most important, is actually the goal when we take the permission. So we send this to the Saudi Health Council, and as you see that they are accepted the clinical practice guidelines, but they sent for us some of the modification we need to do, and in the same times they will look into what's further step to do. And we already get some of the permission, because remember, copyright for all the guidelines which we adapted our pathways from it, we have to take the permission. So already we get 1 and 3 actually to go. Once we do all this, it will come the most important part of our publications, which is to be an open access. It should be access to everybody. It should be in our recognized journal, and from there it will be national for our clinical practice guidelines for the Saudi, inshallah, bi'idhnillah. And you never know, maybe one day will be also international as well. So this is a summary of the clinical practice guidelines for newborns. So thank you so much. Thank you.
Thank you, Doctora, for this nice lecture. Next lecture will be presented by Doctora Rana Al-Maghribi. Doctora Rana, consultant of pediatric infectious disease. She's pediatric antimicrobial stewardship program head. She's the president of Pediatric Infectious Disease Society in Riyadh. Doctora will talk about neonatal sepsis. تفضل.
Bismillahir Rahmanir Rahim. Thank you for the introduction, and thank you for the organizing committee for inviting me. But actually, I don't know if safe to talk about neonatal sepsis in front of more than 100 audience of neonatology. I don't know if it is safe or not, but I hope my husband, he's neonatologist, so maybe he will protect me. I don't know. In this lecture, I will touch on 3 important points in neonatal sepsis. I know we are still struggling in defining neonatal sepsis in comparison for defining sepsis in adult or older children or teenager. The second point, I want to really stress on it. What is the theory of the serum biomarker, and what we have now for the diagnosis of neonatal sepsis and what is coming? From there, I will talk about our guideline with the collaborative with the CNS Society. Actually, over the last 10 years, there is huge advance has been made in neonatal sepsis in form of epidemiology, pathophysiology, diagnosis, monitoring, and treatment. And as you know, originally, sepsis or neonatal sepsis came or derived from Greek word, which is sibo, which means eye rot. And definition of neonatal sepsis or sepsis in general continues to be evolving in 21st century, and it was established in adult in 2016. But still, the concept of sepsis in neonate has proven difficult to be defined, and it is really challenging. A lot of publication and a lot of physicians, they try to find the challenging in defining neonatal sepsis and how we can manage to establish the definition for that. But till now, we don't have a really clear or exact neonatal sepsis definition. But generally what we will use, or what we use to as accepting criteria for neonatal sepsis, are organ dysfunction and setting of infection depending on the infection in the sterile site, either blood, urine, and the CSF. But sometimes in the critical area like PICU or NICU, even if non-sterile site with some abnormality like apnea, brady, or a tachycardia, we referred as a sepsis. With aid of some biomarker, we sent for CBC, CRB, all this biomarker, we use it to help us to identify or guide us in neonatal sepsis. Although we lack really of reliability of this marker. We'll go to the blood culture. You know, the blood culture, it is really wonderfully sensitive and extremely sensitive. If we take the blood culture by proper way and we take the proper amount of volume of the blood, like from 0.5 to 1 ml, and this is, I think, the minimum recommendation by American and Canadian guideline. Dr. Shugalanda, he published this paper in Journal of Pediatric. What they found, if we take 1 ml of blood culture, it will determine even if there is low level of bacteremia. If we have 5, 10, 100, we'll reach to the sensitivity of 100%. But the problem in the NICU, really, a lot of things like sepsis. There is Dr. Dempsey here in Journal of Perinatology in 2006. They mentioned apnea, respiratory distress, and hypotension are 10 times or sometimes 100 times more common than sepsis. Not only that, also respiratory distress syndrome, transient tachypnea of newborn and atelectasis is more than sepsis. Not only it is over diagnosis, but also there is like complication and poor outcome. We know it is a neonatal sepsis carry high mortality, morbidity in the NICU, but not only that. Dr. Schurman in 2019, before pandemic, he published, this is very nice actually, retrospective, cross-section and study in California, California Perinatal Collaborative. He took 326,000 live births, over 120 nurses. They found the median number of antibiotic courses per early onset sepsis is 95. And when we see the number of antibiotic courses per late onset sepsis, it is really 19. So what they found and what they conclude, the number or the percent of newborn receiving antibiotic for neonatal sepsis is not correlated to the proven either early or late neonatal sepsis. We agree with you. As ID, it is really challenging diagnosis, difficult or hard to distinguish infected baby from non-infected, but we believe there is the non-infectious condition may be more common than sepsis. But I want to remind you about the Spartak's character when they want to catch him and they don't know who are, so they kill them all. So this is what happened exactly. If we cannot distinguish sepsis patient from non-sepsis patient, we will treat them all. And here from Dr. John in last year, he put ideal biomarker. It could be help us in diagnosis or guide us in neonatal sepsis. So in general, we have to have like well-defined cut-off level of this biomarker. It has carry high or positive negative predictive value of 100% high sensitivity, and we have to have like biomarker help to identify the neonatal sepsis before it happens. And you know, we are dealing with neonate, so we have to have biomarker need low blood volume and fast turnaround time. For sure, we need low cost and widely available. But currently, actually, we don't have this test to fulfill all these criteria. So what we have now? We have the CBC, and this is very old and original test. We asked for any patient with the suspicion of sepsis. Here, this paper maybe 50 years back, they mention about the facularization or toxic granulation in the neutrophil if it is found, so it will help to diagnosis of neonatal sepsis. But I don't know if this can help us in ICU. So there is two study. Really, it is very clear for us. Maybe it will not help the facularization of the neutrophil in diagnosis of neonatal sepsis. Sorry, I need. Okay, here when we talk about absolute total neutrophil, we found the specificity for it 51, although we have high negative predictive value of 99. But when we compare this one to the immature, the total neutrophil count, we will see it carry really high specificity and high neutrophil negative predictive value. So this might be helpful in diagnosis of neonatal sepsis. In comparison to this is another study, and it is retrospective study done in 166,000 infants with suspected early onset sepsis over 293 different NICU. And they took different value of the CBC. The majority of the infant with the early onset sepsis had normal CBC. So really we have to look on it again. When we see to the CRB, I think most of us, we ask for CRB in the neonatal sepsis, but in this big meta-analysis of 22 studies, including 2,255 infants, they have specificity for 74 and the sensitivity 62. So really the CRB, especially when we ask for CRB in the initial evaluation of patients with the suspected neonatal sepsis, unlikely to be aid in diagnosis. Maybe the procalcitonin, it work or perform better than CRB. This is very big randomized control trial done by Dr. Stoker over 3 years. They include 1,700 neonate, more than 34 weeks of gestation, and they take different serial procalcitonin level at 12, 24, and 72 hours. What they found? They found actually the area under the curve for those patients at 12 and 24 hours, it is poor, less than 0.5. And if we take the procalcitonin at 36 hours, more than 0.9. So as you know, if we have area under the curve more than 5.7 or more, it will help us really to discontinue the antibiotic. But here, the procalcitonin, it helps us. But actually, after 36 hours, it seems to be 36 hours already the blood culture come, the result come, and you will decide to DC the antibiotic. The average antibiotic duration, when they use this study, they found 55 hours in BCT group and 65 in standard of care group. So no big difference, but actually procalcitonin, it is one of the biomarker. We use it sometime in discontinuation in high-risk area in antimicrobial stewardship. What is new now? We have interleukin-6, and this is very recent study. One of them, it is a retrospective cohort study. They include 1,695 infants with 109 culture-proof in sepsis. They found the interleukin-6 with the sensitivity of 75 and specificity of 81 with high negative predictive value. So it is work. We don't know. We'll see the second study. Here we have meta-analysis of 31 study for early onset sepsis with high sensitivity and high specificity, again with high negative predictive value. Dr. Kanti, he said that sepsis in neonate is rare depending on the culture. Maybe it cannot be explained with the high negative predictive value. A lot of biomarker talking or helping in the future to guide us in diagnosis of neonatal sepsis. So what is coming? I think we have to think about the non-invasive biomarker in helping us of diagnosis of neonatal sepsis. 1 minute? Thank you. Okay, so for heart rate characteristic, I think all you know about the monitoring of heart rate. It can help, especially before the baby crash, and also it will help us in decreasing the mortality of the newborn. When we combine the heart rate monitor with the biomarker, it seems to be really decrease the mortality and the antibiotic. I will not go in detail in this three recent study. One of them maybe talked about the intestinal microba, and Dr. Joseph knew, I think he discussed it yesterday or before yesterday. It has a role in finding the patient with high risk of NIC. The pulse oximetry, the BO2 and BCO2, they found it helped us in diagnosis of neonatal sepsis. So we have a lot of biomarkers, but we'll go to Dr. John biomarker. So we have to look to the biomarker, involve all these criteria with non-invasive. I don't know, the last one, septic shock, maybe somebody hear about it, I read about it, maybe in the future we found it. They said this is as a sensor, you will put it in the hand of the infant. If turn yellow, monitor the patient, obtain the culture, and if came red, start empirical antibiotic. I think by this time, if that happened, so no need for ID people. So today, we have to look to the CBC, differential, CRB, BCT, try to trust your blood culture, but tomorrow we have to work hardly on the biomarker with the collaboration of engineering, biomedical, and computer and electrical. Our guideline, this is really a huge work done by CNS. Really, I want to thank our leader, Dr. Jassim, Dr. Yassim, and this is what we need actually. With all this, we don't have unified standard guideline in neonatal sepsis. This is what we need actually, and they did quality assessment of clinical guideline. It is a systematic review. They retrieved more than 4,000 records, and they compare four of guideline. It will publish soon, as Dr. Jassim mentioned. Really, I want to thank them to consider me in this guideline. We are together actually as ID and neonatology. We have in this month the World Prematurity Day, followed by Antibiotic Awareness Week. So this is the role of antimicrobial stewardship with the neonatology in standardize the treatment of neonatal sepsis. Thank you very much.
شكرا دكتورة رنا.
Our next topic is hypoxic ischemic encephalopathy, presented by Dr. Omar Khatib. Dr. Omar, he is a consultant neonatologist at King Fahad Medical City. He is the chairman of Neonatal Accreditation, Compliance Policies and Procedures Committee. Also, he's a chairman of NICU Infection Control Committees and Vascular Access. Dr. Omar, please.
بس اعمل برزنتيشن على طول.
السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم، والحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. ثم أما بعد. Thank you, Dr. Jassim, and thank you, Dr. Amal, and thank you, Dr. Rana, for the presentations on the previous guidelines. I will present the work our group did regarding building a new national clinical practice guideline on the management of HIE in neonates. I have no personal conflict of interest to declare. This study, this work was funded by the Saudi Neonatal Society. The objectives of this presentation is to give a synopsis on HIE in brief يعني, and why do we need a national clinical practice guideline on HIE, and then the journey we took to build our first Saudi national neonatal CPG, مين هم الجروب members, وإيش هي الأجري to instrument دكتور جاسم اتكلم عنها, and what was our search strategy to build this CPG, and then what are the future directions, inshallah. So HIE, probably everybody here knows hypoxic ischemic encephalopathy, أحيانا بنسميه birth asphyxia. It's a devastating condition that may result in death or severe neurological injury in babies who survive. A mild to moderate injury causes parasagittal watershed infarcts in full-term neonates. It can cause bleeds in preterm neonates as well as term neonates. Severe injury causes deep gray matter in both term and preterm infants, and unfortunately there is no cure for the ischemic injury that happens due to decreased blood flow to the fetus before or during birth. But there are ways to prevent the complications or reduce the complications. HIE is a costly disease, مكلف جدا على الحكومات. It's estimated that one case of cerebral palsy that results from HIE in the United States, one case costs $11 million for the lifetime. تخيلوا $11 مليون بيكلف الحكومة الأمريكية على طفل واحد عنده cerebral palsy from HIE. So it's a huge problem everywhere. So it's worth an effort for a quality improvement on a national aspect. And فعلا this is a problem that needs to be addressed. So ليه محتاجين national guideline أو عموما ليه بنحتاج guideline في أي حاجة في الطب؟ Excuse me. So the reasons are to influence practice. إنه إحنا you want to make the practice better everywhere. That's the reason you build an HIE guideline. The aim of the clinical practice guideline is to synthesize the best available scientific evidence and to make it easier for clinicians to stay up to date on the latest evidence-based practice. Unfortunately, and this is one of the challenges that we face everywhere, that some clinicians still think that those guidelines are overly prescriptive. يعني they want some freedom. They want to, they want to treat or manage according to their own beliefs. This is a problem I think most of us face in, almost every institution, that there is somebody who thinks that they know something better than the others. But the guidelines are intended to improve the management by everyone. So if I write a guideline and there is some physician شغال في منطقة نائية, he might know better than me. I will not claim that I know better than everybody, of course. لكن if he knows better than me, then I should be influenced by him. يعني لو هو فعلا he thinks that there is something better in the management of HIE, why should we make it confined to that place? خلاص خلي الكل يستفيد منه. So this is the aim of writing a guideline. احنا بنكتب guideline. If we find that there is a feedback from a certain place that says, listen, this step in the guideline doesn't work, then we as a central group should improve this guideline so that every baby born in the Kingdom of Saudi Arabia will benefit from this new improvement. So this is the aim of writing a guideline. So what did we do? We reviewed all the literature. We critically appraised the quality of recent CPGs. And when I say recent, it means within the last 10 years. آخر 10 سنوات أي clinical practice guideline انكتب في ال HIE على مستوى العالم we reviewed على مدار 10 سنوات. And then we mapped our recommendations. This protocol, as Dr. Yasser Jasim mentioned, was registered in the Prospero, and it was guided by the PRISMA statement. Our guideline review group included 7 expert consultant neonatologists. الآن راح أكتب أسمائهم. One of them with expertise in systematic reviews, 2 consultant OB gynecologists, a senior nurse, a medical and healthcare librarian, and a CPG methodologist with a background in pediatrics. This is the group. Dr. Yasser Amir, he is a pleasure to work with. Honestly, I don't know if he's here or not, but one of the best evidence-based experts in this field. He is amazing, Dr. Yasser. Dr. Jasim Al-Nabris, he's also the CNS representative. دكتور محمد عبد المولى من كينج فهد Armed Forces في جدة. دكتور أيمن تاج السر عبد القادر, a neonatologist in King Saud Medical City. دكتور أسماء المزروعي, she's a neonatologist and neonatal neurologist. We have 2 actually neonatal neurologists في المملكة. واحد فيهم في مدينة الملك فهد الطبية الدكتور عبد الله هواش العنزي, and the other في جدة الدكتورة أسماء المزروعي. Both of them were members of this group. دكتور إبراهيم الحفظي من القطاع الخاص في عسير مستشفى السعودي الألماني. دكتور عبد الله هواش, as I mentioned, the other neonatal neurologist. دكتور ياسر صبر is an OB gynecologist في King Saud University في الرياض. وميس ليال, she is a medical librarian. ميس عائشة الشلوي, she's a staff nurse في King Saud. دكتور أحمد الأيوبي, he's a consultant OB gynecologist مستشفى اليمامة, and myself. مصادر السيرش كانت كل ما تتخيلوا. We did not leave anything, notes, everything has been searched for. So كل ال CPG databases, كل ال bibliographic databases, وكل ال specialized professional societies. So خلصنا search في ال CPG database, رحنا على ال PubMed وال Embase والسينال, خلصنا search فيهم, رحنا ندور في مواقع البروفيشنال سوسايتيز اللي هي الامريكان اكاديمي, الكنديان بيدياتريك سوسايتي, البريتش اسوسيشن اوف برينيتال ميديسن, الرويال كوليج اوف بيدياتريكس اند تشايلد هيلث, والسعودي نيونيتال سوسايتي, as well as also الاستراليان ويب سايتس. سو يعني ما بحثنا فقط في الباب ميد مثلا وخلاص, لا, دورنا في كل مصدر ممكن يخطر على بالكم بالنسبه وين ممكن نلاقي a clinical practice guideline in English. طبعا يعني اشياء اللي هي non English we did exclude. كل اي سي بي جي تم اختيارها كانت اوريجينال دو نوفو, يعني خاصه بهذا المكان. لازم تكون جروب اوثرشيب, يعني ما ينفع ان اختار سي بي جي for review written by one person. This was excluded. Any CPG written by a single person was excluded. Has to be either English or Arabic and with international or national scope, and the draft was according to the PRISMA statement. 2 reviewers, myself and Dr. Muhammad Abdel Maula, conducted the title and abstract screening of the CPGs, and 2 other reviewers double-checked the full text screening, Dr. Yasser and Dr. Jasim. Any disagreements were resolved through a focus group discussion. We met probably 6 times. We have a WhatsApp group that is 24/7 live, where we are discussing any thoughts, any ideas, any conflicts, any يعني أي واحد عنده فكرة معينة بيناقشها في المجموعة, as well as Zoom meetings. The search and the screening for eligible CPGs were updated before the submission of the manuscript. طبعا ال agree to instrument was mentioned by Dr. Jassim. Those are the domains of the agree to tool or instrument. Domain 1 level scope and purpose. Domain 2 stakeholder involvement. Domain 3 rigor of development. Can you bring water for me? Thanks. Domain 4 clarity of presentation. Domain 5 applicability. And domain 6 editorial independence. So everything, as you can see, is objective. We avoided totally ان احنا نكون subjective، ان كل واحد يفكر بمزاجه وبرأيه. لا، خلاص في objectivity. This is the way that we are going through. This is the way that we are going to evaluate all CPGs that will come across. It's an agreed upon tool that every CPG on the search result will be evaluated on this tool اللي هي agree to. Thank you. A total of 4,500 records were retrieved من السيرش تبعنا. 19 from CPG database and professional societies. After the title, abstract and full text screening using Ryan, only 2 source original CPGs were found to be eligible for the agree to quality assessment step. يعني من ال 4,524 result, only 2 guidelines were eligible according to the agree to instrument. ايش هما التو؟ الCPS اللي هو الكنديان Pediatric Society والكوينزلاند اللي هو الاستراليان. Two reviewers conducted the screening and 2 additional reviewers زي ما انا كتبت في السلايد السابقه resolved any discrepancies through discussion. So هذا البحث العظيم، تخيلوا 4,520 result، فقط 2 كانوا eligible للأجري to، which is a very rigorous way to critically appraise any guideline on the planet. Any guideline حطه على الأجري to وشوف هل هو CPG كويس ولا مش كويس. سبحان الله وجدنا فقط 2 اللي هم الكنديان والأستراليان هم اللي فعلا كانوا توب، والأستراليان كان أفضل شوية من الكنديان بالنسبة للسكور على الأجري to. الأستراليان كان higher or more superior than الكنديان. This is the process that we went through اللي هو السيرش والريزلتس وهي الأشياء. By the way, this will be published إن شاء الله. ال 2 eligible CPGs اللي هو كوينزلاند كلينيكال جايد لاين تبع أستراليا. ده التايتل تبعه ال HIE Maternity and Neonatal Clinical Guideline Queensland Clinical Guideline. اليير اوف بابليكيشن كان 2021. والسي بي اس اليير اوف بابليكيشن 2018، لكن في نيو سي بي اس جايد لاين we also included and there is no ما فيش اي significant change yet من 2018. By the way, we took permission from both author groups of the Australian and the Canadian, and alhamdulillah we were granted permission to use them. لأنه before we use any guideline on a national base, you need to make sure that إنه الناس اللي كتبوا هذا الجايد لاين يسمحوا لك باستخدامه في بلدك، عشان ما ايش we have to be legal, we have to be systematic and you have to be منظم، والا you are يعني you are playing a bad role model. تمام؟ نعم؟ بالضبط. Thank you. الانكلوجن كرايتيريا طبعا I will not go through ايش هم الانكلوجن والاكسكلوجن كرايتيريا بالنسبه للهايبوثيرميا، لكن I always tell my fellows that to know what are the inclusion criteria في ال HIE, take it the other way around. HIE متكون من 3 حروف HIE، امشي بالعكس. You need E which is encephalopathy. So first thing you need an abnormal neurological examination, a baby that's presenting with abnormal neurological examination, and then you need the HI as the cause of this E. بمعنى انه this encephalopathy has been caused by an ischemic insult. not by anything else. ليه؟ لأن encephalopathy in neonates can be caused by inborn error of metabolism مثلا, can be caused by intracranial bleed, can be caused by many things, right? But if this encephalopathy is precipitated through an ischemic injury, then this baby qualifies for cooling ببساطة شديدة. طيب إذا ال E encephalopathy is by examination, ال HI is by history. So كان في مثلا abnormal fetal heartbeats أو late fetal decels, كان في مثلا antepartum hemorrhage, تمام؟ And then في مثلا poor cord gas pH, في resuscitation at more than 10 minutes of age, في كل الاشياء اللي هي بتدل على انه الانسفالوباثي سببها ischemic insult. Okay. So those are the inclusion criteria. Exclusion criteria طبعا اي بيبي عنده major congenital anomalies او عنده طبعا اللي على اليسار اللي هو السي بي اس واللي على اليمين اللي هو الكوينزلاند. اوكي. وهكذا الفيدنج السي بي اس تسمح بالايرلي مينيمال انترال فيد. الكوينزلاند ان بي او during الهايبوثيرميا في literature evidence انه الفيدنج is actually safe during hypothermia. sedation كان في اختلافات بسيطه بينهم. الثيرابيوتيك هايبوثيرميا وتارجت تمبرتشر كانوا تقريبا زي بعض. فبعد ما خلصنا review and we discussed the two guidelines, we adapted to a local practice. We drafted the first Saudi national HIE CPG. We got permissions, as I said, and then we submitted for publication. And then the future directions, inshallah, will get feedback من centers across السعودية كلها. We'll check compliance and we'll check the challenges facing individual centers. And inshallah, we aim to update such a CPG every few years to make sure that we are catching up مع أي new evidence في management of HIE. وشكرا جزيلا.
شكرا دكتور. دكتورة. دكتورة أمل. دكتورة.
For the speaker kindly to attend here for the discussion.
طيب anyone has any questions?
For Dr. Rana. Yeah. Yeah, we'll just wait for her.
She can hear you now.
Yeah, it's okay. I'm Buenafe, I'm a NICA professional and NICO developmentalist. And I just want to have a recommendation when it comes to the neonatal sepsis assessment and during the early detection. As a bedside nurse and as a NICO developmentalist, developmentally wise, if recommended, and this is under the European guidelines, US guidelines, and this is found with all the researchers in Sweden and USA. As one of the early detection, if the nurse is developmentally educated and oriented, there are 4 steps that we can assess early detection of neonatal sepsis. Number 1, we have to include the feeding intolerance of the baby for the first 24 hours. And you can find this in the European guidelines about the first step. And each gestational age, they have their own how many ml of feeding they will going to tolerate for the first 24 hours per ml per Q2 hours and per Q3 hours. So in this regards, if the nurse were not going to know about the feeding tolerance of each newborn according to gestational age, they're going to feed according what they want and how they're going. They must be the neonatologist or the physician should give them the proper instruction on how many ml on the first 24 hours, because most of the nurses were going to give according to the like 30 ml ml, 30 ml is not really feasible for the first 24 hours, especially for the small gestational age. So they will going to find out that the baby is vomiting, of course, intolerance.
So what is your question?
So it's a recommendation, doctor, that it should be the nurse should know what is the how many ml they're going to give, because I'm going to give the early assessment in order for them to detect for the early referral as well. So the feeding ml of how many going to give in each gestational age. Number 2 is according to the cardiorespiratory instability and also hemodynamic. They have to be strict on that. Number 3 is the color. If the baby will going to give them the cues, what color they will going to give, the nurse should know that this is already the baby's stress, and giving them already the sign of early signs of neonatal sepsis. And another thing, hypothermia or consistent. In spite of everything that we give, we keep the baby warm, we do the kangaroo care, and there's still the consistent of hypothermia. So this is one of the early sign. And another thing is the nurse should know about the state that not the first 24 hours the baby was delivered and the baby is sleeping. And this is one of the guidelines that Dr. Arana discuss about the interleukin. So the nurse should know all those things. If there are 6 states of baby when they're going to give you the sign. So one of this one is the deep sleep. The number 1 is deep sleep. So they should know that the baby is not sleeping well or what. Deep sleep also one of the signs that for the first 24 hours that early detection of the neonatal sepsis. So this is a recommendation as the NICU developmentalist.
Thank you.
Thank you.
I think the second question, Dr. Abdurrahman, was.
Mike, yes. شكرا جزيلا for the 3 or 4 elite speakers. أنا كرئيس الجمعية كان على عاتقنا أن احنا we have to finalize this guidelines by 2022 and I think almost finished. لكن السؤال for Dr. Jassim, Dr. Omar and the others, how we can implement it? What is the force of our guideline to be implemented national in the private sectors and all institute? If you allow me for the second question, for Dr. Rana, we are not fighting. We are living in peace as neonatologists and ID. And the rule always, when we start to debate, we need to put the antibiotic because the baby is bad hemodynamically, and you want to stop the antibiotic because the culture is negative. What will be our guidelines, or what's the role of the stewardship in controlling this debate and controlling this fight? شكرا جزيلا.
Thank you, Prof. Nimri. Thank you, everyone, for attending this very important session about clinical practice guideline. Honestly, implementation is very challenging, and we think about it in board of director before we start the guideline, and even on the level of teams, we have many meetings, as Dr. Omar and other team mentioned, that we did WhatsApp group, Zoom meetings, and a lot of meetings just to discuss how we can come up with very good clinical practice guideline and how to implement that guideline, not to do as before. We have a lot of efforts before, and it's end up in shelf or anywhere, but not implemented. So from our meetings and our colleagues' mind, we have 3 major issues. We need support, and this was very support from Ministry of Health, Dr. Ali Al-Mudir, from SNS, and lastly we met with Dr. Sayari from Saudi Health Council, and all of them support our initiation and our movement. So support was very well, and inshallah it will give us good indicator that we can go further. The second implementation issue, that we include teams from everywhere. So we cannot say like pediatric ID not involved, so they will agree or disagree, for example, with some of ideas or biomarkers or something like that, or HIE, for example, some neurologist or other specialties. So we involve all specialty, concerned specialty, and we involve even other health sectors. Like private, they can say we are special institute, so we involve private. We involve Ministry of Education, universities, MOH, and all health sector in Saudi Arabia. Last thing was in implementation that we need to consider different resources. And this is thanks for all team again, I'm saying, because really they did a great job that they were discussing MRI and HIE. Should we do it, should not do it, once, twice, at what age, at what time. So they will considering, honestly, maybe a lot of work, it is not written in slides, but it have been done very thoroughly discussion about all those things. So we don't like to say for peripheral area that we do MRI and then they will stuck with our guideline and they cannot do it. So we discuss everything and we tailor it to all resources. If we have very high good center like National Guard or King Saud or any good tertiary center, or we have periphery. So this is three, I think it gives us good future for implementation. Thank you.
Dr. Majid.
Okay, thank you, Dr. Abdurrahman. Actually, before answering your question, really we are not in fight because, as you know, antimicrobial stewardship, it is multidisciplinary team, and you or the other are neonatologists part from our team in antimicrobial stewardship. And it is well known, antimicrobial resistance now, it is really the big problem over the world. Even in by WHO stated in 2035, it will be the first cause of death at that time. So as antimicrobial stewardship, it play a role actually to controlling the use of antibiotic or improper use of antibiotic as a core intervention or a strategic intervention to control it. A lot of literature talking about the antimicrobial stewardship role in ICU, especially. Maybe I didn't talk about it in detail, the publication by Dr. Joseph New, when he's talking about the prolonged use of antibiotic in the NICU can cause alteration in intestinal microbe. So maybe risk for NIC. So to control it, we have to work as a team to avoid improper use of antibiotic, to avoid all this problem with all complications. Thank you.
شكرا دكتور. دكتور مجيد.
Thank you. The way I understand that these guidelines you are presenting, as if they are a legal document and people has to follow. And they are not legal, are they? I know it is good to have guidelines, but you are asking people to follow this guideline, and if they don't follow them, then they are in trouble. And the legal problem in the country is rising. So we have to be very careful when we put the guidelines. As you just mentioned, that people in the periphery, they don't have the resources. And if your guidelines, you cannot have guidelines for a tertiary center and you have guidelines for periphery. You have to have a guideline.
I will answer your concern. What's your name?
Can I finish?
Yeah, go ahead, please.
And if you have a guidelines and people have to follow, and then there's a problem, then the people at the periphery, they are going to be in great trouble if these guidelines fell into the hand of lawyers. Now, let me give you just a simple example. You mentioned that all babies should have a pulse oximetry between 24 and 36 hours. What do you do if the obstetrician discharges the babies at 12 hours or at 8 hours sometimes, and then the baby turns up to have sciatic heart disease, and they see the guidelines, and then why you didn't do a pulse oximetry for this baby, and they will be in trouble. So I think if you want to implement it all over the kingdom, it has to be legally approved rather than only from the society. I repeat, I think we need the guidelines, but it has to be done properly and approved before get implemented.
طيب بسم الله الرحمن الرحيم. هو أنا يعني I'm the chair of policies and procedures committee في King Fahd Medical City for the last 5 years. And so what you are talking about here is the difference between a policy and a guideline. If we titled this document as a policy, then every center across the kingdom has to follow precisely. A guideline هو دليل إرشادي that gives a range of practices to follow. Is it a legal document? It is a legal document. Not yet, but it will be a legal document. If an obstetrician discharges an infant without a pulse oximetry before the 24 hours, he needs a justification for this. We are not saying you are malpracticing, but if you don't follow the guideline, then you as a physician need to justify your practice. A policy, no. A policy you should follow, and if you don't follow the policy, you are malpracticing basically. So a guideline, if we go through what we wrote in almost every guideline in those presented, you will find that there is a range of acceptable practices, وفي النهاية في clinical sense. يعني أنا لما أكتب guideline براعي جدا انه في حاجه اسمها clinical sense، في understanding، في difference in practice. It's في range I can choose from. But yes, I can not follow sometimes. I'm allowed to. ولذلك مكتوب مثلا ال MRI if available. So أنا as a guideline writer, I know that some places don't have MRI. So what if I don't have MRI? Then ultrasound can replace the MRI. So, and that's why, as a writer, you need to give the people options. So, is it legal? Yes, it is legal. لكن هيعتبر legal في حالة إن هو أنت, if you don't follow, then you justify, at least justify. That's it. As simple as that, يعني.
If you allow me, Dr. Majid, just to say.
Can I think.
Dr. Majid, let's just finish because you asked us a very important questions, and we need to address that important questions. And I will be in the hard side. What I mean, I will be in the hard side. In the hard side, whenever we do a clinical practice guidelines, you look into all the issues you mentioned. We look into the legality. We look into the applicability, and in the same time, we look into the obstacles and the challenging. So what you are mentioning, Dr. Majid, this is a challenging and this is an obstacles as well. So this is the reason behind the first question Prof. Nimri asked Tamam Jasim about the applicability and how we will do that. We know that the whole kingdom, there is a peripheral hospital, there is a primary, there is a secondary, there is a tertiary. In fact, you help them out by these guidelines to say, wait a minute, I have a problem here. So the policy makers, as I indicated in my presentations, they do the quality improvement. What we have the issue here, how we can address it from the legal point of view. In fact, I'm more right now into get that clinical practice guidelines as soon as possible. It's just to overcome this challenging and to overcome this obstacle, Dr. Majid. Thank you.
شكرا دكتور عمل.
Thanks for the speaker. Assalamu alaikum. Sabah al-khair. The question to Dr. Amal, as you mentioned, the newborn care is very important, and this address like 90 or more than 90% of the babies. My question regarding the involving the mother in the care and rooming in the babies to their mothers. I hope you mentioned this in your guideline, because in many places the babies are separated from their mothers. And then probably also another point is the post-discharge care and the follow-up. follow-up again is very important, and probably we need like written materials for the mothers to read a standard, something from the neonatology society for the mothers to follow exactly what is written, because there are many things written or in the internet or so, are the companies, especially the formula companies, they formulate a lot of things probably we don't agree with. So I think these points needs to be addressed in your guidelines.
Absolutely, I agree 100% with you, and already we are going into that, because the information has to be clear for the parents from the beginning, and the beginning actually from the antenatal, even not postnatal. So everything should be set from the beginning. So I agree with you 100%, and already we covered part of it, and we will continue to cover all of it, inshallah, bi'idhnillah.
Thank you for the speaker.
If I can, Dr. Rohit, if I can have 1 minute, Dr. Jassim, هنا.
تفضل.
Just 1 minute, sorry, because we are late, but a few points I left it from my presentation because of time. We face a lot of obstacle, and what we are discussing today, it is reflecting that the issue is not simple. And all teams from different sectors, from different specialty, sit many times and discuss, and we disagree with each other, and we try to find what is more suitable for our society and national guideline. So we have a lot of obstacle. Team with different specialty to bring together, team with different opinions from different health sectors to motivate the team. It was very, very challenging to us. It's not just the final words what we are presenting, but really it make us give us a very hard time. Also the concept of clinical practice guideline was a very new concept for a lot of us. There is, as usual, we discuss in many places that we have a lot of guidelines, a lot of policies in different health sectors, and everyone like his sectors. There is a lot of groups pop up after we start, and we try to accommodate them with us just to make one group working, so we have better implementation, as Prof. Nimri said, and this has happened many times. There was a very big challenging with health reform that rules were changing. Saudi Health Council versus Al-Hayat Saudiya versus Ministry of Health. It was a lot of change. So even our change in the guideline was delayed because of that. We were following Saudi Health Council, then we changed to another, then Al-Mawarid Al-Bashariya, then it gave us sometimes delay and some consideration in between. Copyright permission, as Dr. Umar said, that we have agreement for HIE, both of them, but we have rejected by NICE, and they request very high, 50,000 riyal just to give permission for ADAP. So we have even the permission challenge. The feeding protocol, already we started with a very distinct group, but we couldn't progress with that because of that we need de novo group, but we put it on the second wave guideline, which is very important feeding protocol. We have one which is working very well, but we need to upgrade it. I want to say to all our colleagues, like Prof. Sajjad what said yesterday, you are most welcome, anyone, to participate with second wave. If anyone like to participate, please send to society your name, and you are welcome. NIDCAP professional, we forget, I think, to involve. Sorry, Benef. I think NIDCAP professional, very good specialty we need to involve. Last thing, please, what we present is still not finally approved. So if one make a screenshot of hard copy, use it for your personal, but inshallah after final approval, because for sure even final approval it need some changes and editing, then you are welcome to use it, and thank you.
Thank you for our speaker. I think we can end sorry for this because of the time. Dr. Nimri, you can go for a break.
I know, just to answer Abbas, we have now Majallat al-Walid. It's in Arabic, it's mainly for the mother, and you can get the second, inshallah, volume to be with you. Your responsibility to write for us what is the post-discharge plan. Well, inshallah, tam. Halas. So this is الوليد journal and Abbas is going to get and write the second issue بإذن الله تعالى. شكرا جزيلا.
So you can go for a break for 10 minutes. Half an hour, okay.
Half an hour.
Okay. Half an hour, 30 minutes. Thank you very much.
مع السلامة.